Good afternoon and welcome, everybody. It's not exactly the most pleasant of days. It's blowy, it's windy, but we've got some good news. The good news continues. You'll hear from Dr. Brink in due course. And today there's just me and, of course, the omnipresent Dr. Brink. So you've got the very good in her and you've got the indifferent in me. We'll hopefully have a full panel on Friday. And the reason for that is that we'll have more information on Friday. And I'll come to that in just a moment or two. Now, the good news is our good friends, fellow Bailiwick Islanders in Alderney and Sark are now in phase 3. We at the CCA will be making a decision next Tuesday about when we in Guernsey move to phase 3. But unless something untoward happens, we're very, very likely to make that decision. It'll be on Monday, the 22nd of March. So I know that still seems a long way off, but it isn't really. We're moving through this as quickly as we can. We don't want to delay it a second longer than we need. We don't want to precipitate it and open it up and then have to go back a stage or two. So the firm favourite is the 22nd of March. Now, we also say in 2 media interviews recently, I said something which may seem conflicting, but they're not. One, I said that in a year's time, in answer to a question, we'll be looking at COVID from the rearview mirror. And the other, I said COVID will be with us for some years. Both of those are consistent because when you drive away and you look in the rearview mirror and you're looking at a building, it's still there. So COVID will still be there, but because of all the tools in our bucks that we've now got and that we will undoubtedly develop further over the next period of time, we'll be able to, again, all things being equal, subject to all the caveats that we have to express, we'll be able to live with it. We'll be able to deal with it. We'll be able to make sure that our community can function. Because when we move back, as we hopefully will in a relatively short period of time, to phase 3, that's the Bailiwick opening its internal economy, its life going back to as normal as it can be. There may be some considerations about things we may have to do. I don't mean will be restrictions. There may be, if there's going to be a big gathering, there may have to be some kind of assurance that it can be done in a safe way, etc., etc. But that doesn't mean to say there are going to be any undue restrictions. Now, what we in the Civil Contingency Authority did yesterday, and what we're doing again tomorrow, is discussing what's called the Bailiwick Blueprint. Now, the idea of that is that how then we can open up our borders over a period of time. Now, we've made absolutely no decision in relation to that yet, but we expect to be able to say something to you in a meaningful way on Friday. Again, at media interviews, I said I thought I'd be doing that next week. I actually think I'll be able to do that on behalf of our community a few days earlier than that. Now, whatever we do, it'll be caveated. There'll be conditions because, again, who's going to know what's going to happen in other jurisdictions? And we want to make our jurisdiction continue to be as safe as it possibly can be. But we want to give people hope because this has been very, very difficult for people. It continues to be difficult for people. There are the financial consequences, which are dreadful. But there are even more people's health, physical health, just as important their mental health. And we know that people want to be able to travel out of the bailiwick. They want to live their lives as normally as they can. We want to get there too. Now, let me not be Mr. Scrooge, but I've got to say one thing, because when we've got these disposable face masks that we wear, when you dispose of them, can you dispose of them in a waste bin, please? Not on the ground, not in your recycling bag, not down the toilet. Because there are lots of them, hopefully, because people are wearing them and they should be satisfactorily disposed of. Anyway, the idea is, as has been throughout the last year, whoever sits in this chair is to give you as much information as we can, as openly and transparent as we can, because that's where we want to be. And we're hoping that we'll have more concrete news for you, subject again to the caveats that I've expressed on Friday. Anyway, enough of me and over to Dr. Brink.
Thank you very much, Deputy Fairbrash. And just starting off with slide 1, it is indeed good news for us today. We're now 11 days with no new cases. And on top of that, we now only have 1 active case. So if we look at the numbers from the second wave, starting on the 22nd of January, we've got a total of 511 cases. 510 cases of the 510 cases are now closed. Thankfully, the overwhelming majority of those have recovered completely, and that's 509. But we, of course, did sadly lose 1 person. We have 1 active case left, and we have that person within our hospital. And really positive as we move forward. So if I can have the next slide, please. So one of the things that we're doing now is we're looking at lessons we've learned and also what we can integrate into our future management of COVID-19. So I have shown you the slide before, but I want to discuss it today with a slightly different slant. So this shows our second contribution. So as you can see, the overwhelming majority of cases, just under 3/4, were detected through our contact tracing process. Now, that is a huge testament to the efficiency of the processes and the fact that often they were working till 10, 11, 12 at night to make sure that the contact tracing was done as soon and as efficiently as possible. But within that process, we also identified some lessons we can learn. And what we're doing now is we're integrating this into information that we can present to all of you as a population and say, this is how people became contacts of cases. So think about meetings in closed rooms with poor ventilation, just as one example. So that's been important. We've also thought about the new viral dynamics of the variant and whether we should modify our contact tracing process at all. And we will be going back probably 72 hours now before someone becomes symptomatic, should we see another case. And that's just really important as we continue to evaluate and look at our processes. And as you can see, about 1/4 of people within that group were symptomatic and seeking healthcare. So really interesting. Good news for the contact tracers, how efficient they were, but now let's look at how people became contacts and how we can integrate this into our future management. So if I can have the next slide. Another thing that we looked at this weekend was the number of tests performed during each wave. So we have wave 1 of the pandemic, which was from the 9th to the 30th of April 2020, and we had wave 2, which was the 22nd of January until we saw our last case on the 26th of February of this year. Now, taking a step back from the waves, I just wanted to talk about our absolute test capacity. And we've just had the 1 year since we diagnosed our first case of COVID-19. And at the time that we diagnosed the first case of COVID-19, we could do 35 tests a day. And those 35 tests had to be sent to the UK. And we often, because they were really overwhelmed and busy themselves, we often waited 3-4 days for that result. So we weren't doing management of cases in real time. If we fast forward to where we are now, and at the end of our second wave on the 26th of February, our test capacity had increased 50-fold. So it's gone up to 35 a day to round about 1,500. At a push, we could go up to 2,000 a day. Now, that's been because we've developed our own on-island testing capacity, and our ability to do this genetic analysis will impact on our ability to look at a number of other respiratory viruses and indeed other infectious diseases in the future. So we've developed a huge skill set on the island, which is going to be beneficial as we move forward. But if we then look specifically at wave 1, as I said, occurring between the 9th of March and the 30th of April, we had a total of 52 days in that wave, and during that time we did 3,752 tests, and we were averaging about 72 tests a day. And at that stage, that was a huge increase from what we were previously being offered, and this was due to our on-island testing capacity being developed very early on in that first wave. But we still recognized that if we were going to move forward, we needed to enhance our testing capacity to not only consider testing people with symptoms, but also what you've heard me talk about this time is the surge testing and the planned workforce screening. So if we then fast forward to the second wave occurring between the 22nd of January and the 26th of February, we had 35 days in the wave. Now, despite this being a more infectious virus, we had a shorter time in the wave of infection. Now, I think that's due to 2 reasons. The first is the very effective rollout of the vaccination program, and secondly, no doubt about it, our test, trace, and isolate program. We were able to test very proactively, isolate contacts very quickly, and break those onward chains of transmission. During the second wave, we did just under 30,000 tests, so an enormous increase, and we were averaging 855 tests a day, and some days going to well over 1,000 a day. So what this shows is the development on our on-island testing capacity, the refinement of our contact tracing processes have enabled us to manage the second wave more effectively. So that was really encouraging for us. So if we go to the next slide, I'm going to focus the last two slides and talk a little bit about vaccination. Now, we're very fortunate to get 5,000 additional doses of vaccine this week, and we're very grateful to receive those. And we're planning to integrate those into what we deliver over the next week. So our next weekly shipment, we're expecting 975 doses of the Pfizer vaccine and 7,640 of the AstraZeneca. So really positive. What we're doing is a community vaccination centre will now be opening over a 7-day period for this time so we can deliver an enhanced vaccine capacity. So we'll open it as much as we need to deliver those additional doses of vaccine. So we're very pleased to receive those and we're looking forward to delivering them to islanders. So if we go on to the next slide, please. So the final slide that I've got today summarises our vaccine statistics. And if you look at those, you can see from the graph, just about 31% of our population have now had at least one dose of vaccine. So that's 21 have had one dose of vaccine, I think 10 or 11% or 21% have had one dose of vaccine, and 10 or 11% have had their second dose as well. So we also measure the total doses per 100 population. We do that because we know it's an international comparator. And we're now on 37 doses per 100 population. And to date, we've delivered 24,346 doses of vaccinations. So really pleased with those results and really a huge testament to the community vaccination centre, but also the partnership working that we've had with primary care, community services, specialist nurses and so on. The final thing I wanted to say was a message from our head of acute nursing services, Elaine Burgess. Now, Elaine and I work really closely together, and indeed we work really closely with Dr. Raby as well. But she wanted to thank everyone coming into the hospital to visit relatives. She said everyone has worked with them, their behaviour has been exemplary, they've come in, washed their hands, worn their masks, and really, she said, the cooperation from relatives has been absolutely exceptional. So she wanted me to pass her personal thanks on to everyone for working so closely with the nursing teams within the PH. So thank you to everyone, and I'm going to hand back to Deputy Fairbrass now. Thank you.
Thank you very much for that upbeat and factual report, as always, Dr. Brink. Now, just a couple of things before I hand over to the media for questions. And they're really, we've heard the exemplary way in which people have visited hospital to see friends and relatives, etc., etc. Let's continue that, because look at our retailers. They've had a terrible time. So when you can shop locally, buy locally. Don't always think I might be able to get this 5p cheaper if I can get it from Amazon. Think of the people that are producing the community that we've got and opening their shops. Buy Guernsey, buy often, spend your money with Guernsey shops. And also, I don't really care if it's gender biased or whatever, but I'm too old for all those things because we're all equal, etc. But it's Mother's Day this weekend. Whether your mum is young, old or somewhere in between, she's done a great job for you. A lot of mums have had to not only look after the kids, they've had to homeschool their children, they've had to still look after their families. So reciprocate, buy them presents and buy them local. Anyway, enough of me. Media, your questions, please. Can I? Yes, Hamish, your hand's up first. So, yep.
Thank you. Yes, Deputy Fairbrass, you mentioned not necessarily restrictions beyond stage 3 within the borders of the Bailiwick, but you mentioned perhaps rules on gatherings. Just mentioning that may come as a big concern to people like wedding organisers, for example, about what you may be considering.
No, it's not. It's just Dr. Brink could probably use the same, but just some kind of statement about what you're going to do just to make sure it's safe. Not going to suddenly say you can only have 40 people at a wedding or 60 people at a wedding. If you want 150 people at a wedding, you can have 150 people at your wedding. So it's nothing like that. It's just, if it's a big gathering, public health would want to say, well, can you just tell us what you're doing so that we can make sure that we can give you some guidance? Is that a fair statement, Dr. Brink?
Yeah, I think it is. I think what we're saying is if you're going to have 150 or more people, that we wanted to make sure that there were enough toilet facilities, there was good hand hygiene, and so on. So it's really making sure. And actually, I think a lot of people are already doing this, is they're integrating good hand hygiene, good respiratory hygiene, etc., into our new norm. And I think that's important. What we don't want is a super spreading type of event related to a large gathering. So we're just asking people to please think of the good habits that we've learned during the pandemic and integrate those into the management of any gathering that you have.
Thank you. Juliet Puto. Good afternoon, Juliet. Your question, please.
Good afternoon. We've obviously been making great progress in recent weeks. There's been lots of testing going on, and obviously what we've seen is that we've very much got things under control within the community. We've seen lots of people asking why we couldn't possibly move to phase 3, stage 3, maybe a little bit earlier, maybe this Monday. Can you just possibly give the reasonings about why you feel we need to wait that extra week?
Yep, good question. Because the schools only opened on Monday, Tuesday. Lots of people went back to work on Monday, Tuesday, Wednesday. We need to have a week and make sure that there aren't going to be any problems. We don't envisage any. And then, because so many people are back now in the community, actively in the community, we'll make a final decision next Tuesday. But the very strong likelihood is that it'll be the 22nd, as I said earlier, just to make sure that we go forward in a sensible way. It's not being unduly cautious, but sometimes there's that phrase, isn't there? More haste, less speed. Do you want to add anything, Dr. Brink?
Just that we don't want to go backwards. So giving us those 2 weeks clear between stage 2 and stage 3 will enable us to monitor if something bubbles up. We've got a huge testing capacity. We've turned our testing capacity onto the surveillance side of things. And if we detect any cases, we can then rapidly extinguish and test around that to enable us to go forward. I think the most damaging thing is for us to go backwards. We need to keep going forward. So it's just to make sure that we keep that forward trajectory.
Matthew Leach, your question, please.
Thank you very much. Wave 2 has seen more than double the infections now, but a death rate significantly lower than Wave 1. Does this show the efficacy of the vaccination programme, and does this mean we could potentially avoid a lockdown if we end up facing another outbreak?
Dr. Brink.
I think undoubtedly we've seen the efficacy of the vaccination programme. You've just got to look at the number of people affected in the older age group, but also the absence of mortality, so the absence of death in those groups. So undoubtedly, the vaccination is having a huge positive effect. I think the other thing that I would like to stress here is, although we've seen more diagnosed cases in Wave 2, we've used a huge testing capacity. So, for example, we are testing all contacts of cases, something that we didn't have the testing capacity to do in such detail in the first wave. So we're detecting more cases as well. With regard to whether it prevent us going back into lockdown, absolutely. As we get more of the population vaccinated, the chance of us having to go back gets less and less. And I think that's really important. And I think the vaccination has always been something that we said is really the light at the end of the tunnel, enabling us to move forward. If we saw a cluster of cases, we wouldn't necessarily go back into lockdown. And I remind you again of November last year. We had 11 cases within a few days. We didn't go into lockdown because we were pretty sure that this was a common source and we could actually control it. So even if we were to see a cluster of cases tomorrow, obviously hope we won't, it does not necessarily mean that we'll go back if we feel we can control it.
Yeah. Jim Delbridge, your question, please.
It's a question of clarity, really, panel. This weekend, local restaurants, I'm sure they're going to be extremely busy. Can you just clarify the guidance regarding people from different household bubbles eating together on one table of 10? Now, the guidance says we should aim for 1 metre distance between diners, and it's the word aim that's the key here. Will diners be asked to leave if there's not quite enough room, if they can't get the 1 metre between people? How will it work?
You've heard, I don't know if you can see on the screen, I can see Dr. Brink nodding no. Dr. Brink.
Yeah, so again, what we'd like to say is we need 1 metre between tables, but for the 10 diners on the table, there doesn't have to be 1 metre social distancing. What we're saying, it is better to space people out. Going back to the World Health Organization principles, it's better to space people out as much as possible. However, we live in the real world and we understand that that is not always possible. So it's aim for that, and at the same time, keep your hand hygiene on. If you get up to go to the toilet, put your mask on. So we're just asking everyone to work with us and prevent infection where we can prevent infection. But there are some situations where you might not be able to put a metre between each chair at the table, and we quite understand that.
Thank you. Ewan Duncan.
Good afternoon, Ewan Duncan from BBC Guernsey. Quick question about the vaccinations. Welcome news that we're getting extra vaccines for the Bailiwick. A sort of double question, if you like. Why are we getting these, and are we going to continue to get more? And also, at the end of stage 6, I remember from last week's briefing, you said about 6,600 people in that category. That will be almost up to about 40% of the Bailiwick vaccinated. Is that correct?
So I would have to go back and do those figures carefully before I commit myself on a press briefing. But to answer the first question is why some more vaccine became available, and we were asked if we wanted it, and we said yes, because we have the capacity to deliver. And we've always said, Ewan, that the issue is not how fast we can deliver it. It's the vaccine supply. We will get what we can and deliver it as fast as we can. And again, it's a huge testament to the work of the Community Vaccination Centre, because, when we said we've got 5,000 extra doses of vaccine, the sort of responses, that's fantastic. Let's work out how we can deliver it. So it's a real can-do attitude. So very positive. And if we offered more in the future, again, we'll take it.
Thank you. Well, I think you're saying it's ad hoc, isn't it? This block came up. There's no guarantee we'll get another 5,000 extra. No, but what you've heard loud and clear is that if they come up, we'll take them because we can use them. Hamish Shaw, next question, please.
Thank you. Yes, another question on the vaccines. We had a call from a member of the public today asking about proof of vaccination. She wants to go on a cruise, for example, whenever that's possible, and is hearing that she will need a vaccine passport. I know that that's largely out of our hands, but has there been any development on that front that you could update us with, please?
We were talking about that just before we came on air, weren't we, Dr. Brigg?
Yes, we were. So the answer to that is there isn't a standardised form that we're aware of yet, but there's a lot of discussion going on in this field. So what I have said to people, if they have a particular requirement and wish to make a particular booking, they need to have a look at what information they're being asked for, because a vaccination passport may mean one thing to one person, another thing to another person. So what we're going to be looking to do is, the moment there is some sort of internationally recognised standard, we would absolutely look to developing a similar thing for the Bailiwick. However, in the interim, if someone requires specific information, we can help them with that. But also, that's why we are giving people those cards at the time they're vaccinated, because some providers are quite happy with that as a proof of vaccination.
Thank you. Juliet, your question, please.
Keeping on the subject of vaccines, I think you said currently we're obviously on the 60 to 65 age group. Is that correct?
We're doing group 6. We're doing the clinically vulnerable group, the at-risk group.
Okay, I think we've had some queries from people who are obviously watching what's going on in the UK and seeing that obviously in the UK people who are in the 56 to 59 category are now getting booked in. How does that, obviously we're keeping pace with them in percentage of vaccine we're getting. Why is there possibly been this slight disparity?
We've got an extremely good vaccine uptake, and I think the vaccine uptake in the UK is variable in some places. We're having an incredibly positive response from our community, which bodes very well for our future herd immunity. And so, as I said, we're giving as much as we can, and I think we're just having a really good vaccine uptake.
And also the statistics that Dr. Brigg has told us about, we are very, very high, that we're above the UK. We are percentage-wise of the population vaccinating more people. And also, we may not like it or not, but we have our population is generally a little bit older in the UK as well. So we tend to have percentage-wise more in that particular group. Matthew, your question.
Just to quickly check something.
Yeah, sorry, Julia. Sorry.
No, just because you mentioned vaccine uptake being very strong. What has been the vaccine uptake been like then? Can you give us any indications?
Yeah, so it's a piece of work we're doing at the moment, Juliet. What we've got to, and it probably reflects my desire for completely accurate data. So what we need to make sure is we're counting our numerator and denominators properly. So, for example, someone could be over 60, a healthcare worker, and in a risk group. So what we're trying to do now is sort out exactly how many. So we've done an absolute calculation of 44,000 by the time we get to priority group 9, but we know that there's going to be some overlap. So to calculate vaccine coverage and percentage uptake is we're working to define those groups, within those groups more clearly, and we'll then be able to calculate our percentage uptake from there. We think we should have something available in the next week or so, but we just want the data to be accurate, and I do like data that goes out from us to be accurate and to be checked.
Thank you. Matthew Leach, your question.
I just wanted to follow on quickly from the immunity passports conversation from before. Are there concerns that young adults will be disadvantaged given that they will be the last ones to receive their vaccinations? Are there ways this potential problem could be tackled?
I think that's such a difficult one, and I think we have to go back to the aim of the vaccination program. The aim of the COVID-19 vaccine program is to prevent morbidity and mortality, so severe disease and death associated with COVID-19. I think we will get to whole population immunization, but going back to our experience in the second wave, where we had one death compared to 13 confirmed deaths in the first wave. So we need to immunize those people that clinically need it, but I absolutely understand the frustrations of younger people.
Jim Delbridge, your question, please.
Possibly a question for Paul Whitfield, but hopefully, Deputy Fairbrass, you can answer it for us. Will you be extending the co-funding scheme for businesses? Obviously, a lot of businesses are playing catch-up. People like the construction industry trying to get stuff over from the mainland, etc., etc. Will you be extending it through March?
Well, that's not really a question for Mr. Whitfield. Extremely able, conscientious civil servant he is. It's a political decision. It's a decision for policy and resources, of which I am the president. And we are considering that with our very able colleague, Deputy Mark Hellier, who leads on Treasury matters. Those considerations we're looking at them all the time, Jim. We have regard to them all the time, regard to the situation as it is. Who have I missed? I've missed you, Ewan. Your next question, please.
Yeah, another question about the vaccination. So I suppose now that Boss is yours open again, and I know it's been segregated in terms of coming in for sports and leisure and coming in for your vaccination. What's the vaccination centre going to look like in phase 3? And a question from a listener, when will they be able to open the theatre again?
Okay, so phase 3 of the program would be children. So phase 1 of the program is to priority group 9. Phase 2 is from the over 16s to up to 50 or 49 years old. And phase 3, no one has even thought of mapping out because the studies of vaccination in children are still going on. So,
sorry, my apologies. I should have said stage 3 of the exit from lockdown. Apologies.
Okay, right. Okay, I get it. So with regard to where we deliver the phase 2 of the vaccination program, which will be delivered in stage 3, I think we need to, that hasn't been decided yet, but we'll certainly need a mass vaccination type of mass vaccination centre. We think there are around about 22,000 people in that group, so we'll need to look at it.
Yeah. Hamish, your question, please.
Yes, I mean, this has been discussed on many occasions, but questions still come from viewers, and it's worth just reminding them of the basis for this. There's another question about the vaccination rollout. In the past, when we've been talking about phase 2 of the vaccine rollout, teachers, police and prison officers have been mentioned. This viewer is asking about hospitality workers who potentially meet many different households on every different shift, and asking whether they will be prioritised in phase 2.
I think the answer is that's a very good question. We're looking more at the teachers, etc., etc., etc. But of course, again, we'll get advice from Dr. Brink. It'll depend what we can do, what we're allowed to do, what freedom we've got, and also getting people vaccinated as quickly as possible in a cogent way. Is there anything you want to add, Dr. Brink?
No, I think that's entirely correct.
Thank you. Juliet, your question, please.
I've seen some rather lovely posts on Twitter this week about Operation Friendly Face, which I believe is the rollout of the rollout of vaccine for people with learning disabilities. Can I just check, obviously, details about what's been done to try and make these people feel more comfortable in those settings and how it's been going?
Dr. Briggs.
I think we've had a lot of positive feedback from that, from the sessions. So, for example, people have gone in and can go in with their carers. So the waiting area was redesigned to allow people to sit alongside their carer. The vaccinators had a picture of their face, because obviously if someone comes to you in PPE, and we are still vaccinating in PPE, they have face visors on and so on, and it can look quite scary. We've also looked at the sensory stimulation in that area, not have loud noises, prolonged vaccination times, so not 10 minutes, longer periods of time, so that if people need to talk about it, need further explanation, need some time just to get used to the area before they go through to vaccination, some easy read documentation. So all of that's been put together. And I think that's been of fundamental importance. And the feedback that I've had to date has been enormously positive. And again, thank you to all of the carers and all of the people getting vaccinated for working with us. We've also done simple things like offered the carer vaccination at the same time, just to try and make the whole process easier. So it has gone well, but it's to the credit of everyone who's worked within the vaccination centre and within the learning disability services. So it's really a real team effort.
Thank you. Matthew, please, your question.
Thank you. A question I'd like to pose to both of you. Are there any major or notable lessons that have been learned from this second lockdown in terms of preventing an outbreak from happening again, the way we initiate and exit lockdowns, and the decisions made on restrictions?
Yeah. Well, Dr. Brink's got a much quicker brain than me, so I'm going to give myself time to think while I pass the question to her first.
I think we've already started on those lessons learned, and I think I've presented some of those in the slides. So, for example, we've looked at our contact tracing processes, particularly taking into account the increased infectivity of the variants. So with our contact tracing, we'll probably go back 72 hours. Now, what we saw sometimes, and when we talked about source isolation, which I think you heard me talk about a lot when we were in the middle of the wave, is we'd have someone who was positive, would go back 48 hours, and then we'd have another person come up positive who was just outside the 48 hours. And so we thought it would be useful to go back to 72 hours, or certainly look at the 72 hours before someone becomes positive or symptomatic really carefully. So that was the one lesson. The second thing is we did look within the contact tracing as how people became contacts, so how we as a community can avoid getting ourselves into certain situations. And we're producing some comms on that, because there's some really simple learning lessons like, don't all crowd into a tiny meeting room in the morning and have your morning briefing. Think about how you can do it. So just simple things like that. I think what was good was our testing capacity. That certainly saved us in our contact tracing capacity. So I think as we go through, we'll continue tease it out and continue to learn lessons. But those were some of the sort of immediate things that spring to mind.
And for my part, I'm grateful to Dr. Brink to give me that time to think. But and I don't mean to be glib with the answer. Really fleet of foot and quick in action. I think that's the point. That you start off with this, which was a shock to me in the way that it came about, but how we've been able to react to the situation. And if we do get further cases, Dr. Briggs referred to one of her early answers, clusters, once we're post where we are now, that we can deal with it, that we've got the procedures to deal with it. We're ever resilient. We're building up ways to deal with this all the way through as we go through. So, you've never learned all the lessons. It's a bit like I've been a lawyer a long, long time now. I still learn things. And it really is, it really is learning the lessons, anticipating problems, even if they don't occur, so that you're prepared. Jim Delbridge, your question.
When we finally get around to lifting the restrictions and being able to travel away, how quickly will the infrastructure such as airlines, Arini, the shipping, etc., and all the infrastructure that goes with it, be able to react and get us up and moving again?
Yeah, well, it'll take a bit of time, but you've already heard that Condor from a certain date will be ready and willing and able to go. And Orkney, again, it'll take them a bit longer to get to certain routes. They've got airplanes and pilots that'll be able to spring in action not automatically, but in early course. It'll take a period of time, but not too long, because we're giving them, when we make our announcement on Friday, we'll be giving them dates that we expect to be able to work by. So that will give them notice that from whatever that date is, X, Y, or Z, that the borders will be open in whole, in part, or somewhere in between. Ewan Duncan, your question, please.
Sorry, apologies. I think my last question was quite unclear. What I'm trying to ask is, both Azure is now open to the public and those coming for vaccination in this stage. When we move to the next stage of the exit from lockdown, how will that differ in terms of segregation and in terms of the people wearing PPE? And when will the theatre be open? Sorry, I was unclear last time.
That's fair enough. Dr. Brigg.
So we will look at PPE usage. We're not ready to stop doing it yet. I think we need to get ourselves into stage 3. But as we get into stage 3, we'll relook at whether we feel it's necessary to continue with PPE. But that's a decision we need to sit down and talk with the vaccinators about. So that's the first thing. The second thing is when Beausejour would be back to normal. I think that's not a question for me to answer at this stage, and I think that will be part of the plan as we move forward.
Indeed, it will be. It will be. We haven't developed that fully and finally yet, but we will be doing that. Juliet, your question.
Yes, it's another vaccine question, I'm afraid. And this time it's a question about young people, and it's got 2 parts to it. One is just on the JCVI guidelines in Group 6. In the UK, it starts from age 16. In our guidelines, it says we're starting from age 18. I was just trying to find out why that difference was in place. And I also wanted to ask, obviously, about the research that's taking place into giving vaccinations to younger people, because I think that research is taking place currently and what we think about it.
Yeah, Dr. Brigg.
So first of all, for the at-risk groups, we are looking at the 16 to 18-year-olds as well. The AstraZeneca vaccine is only licensed for use from 18, whereas the Pfizer-BioNTech is 16. So we just have to coincide that with Pfizer-BioNTech availability. With regard to immunization of children, I think it's a really interesting question. There's studies, quite a few studies now going on about the immunization of children. I think it would be a good thing, because if you don't immunize children, the virus will continue circulating in that group, and you'll get continued from time to time, you'll get mutations appearing. I think the challenge for us is that it's an injectable vaccine. So if you think of the flu vaccine, we deliver it as a nasal flu. For children, it's a nasal flu vaccine. So we'd have to think of all of those technical, logistical issues that we'd have to think of more clearly. But I'm very interested to see the results of the children's immunization studies.
Thank you. Jim, your question, Jim Delbridge. Hello, Jim. You got a question? Your hand's up. Perhaps you haven't. Okay.
Sorry, Peter. No, I haven't got a question at the moment.
Okay, fine, that's all right. Sorry, Jim, you left your hand up. Never mind. Juliet, your question. You're the only person with your hand still up, so we come back.
I think I've got a couple more questions if the panel does have time, but I'll try and keep them relatively short.
All right.
One relates to, if we look across the water to Jersey, they're currently planning, in case that if they do have problems with supplies of vaccines, they've considered whether to give a different second vaccine to what people have had with their first vaccine. I was just interested to try and find out whether we've considered that and what our thoughts are about it.
Well, I think the JCVI advice is that you should use the same first and second dose of vaccine if at all possible. So that is preferable. So we would do that as our first choice. What JCVI does say is that you can use a different second dose of vaccine if it's not possible for whatever reason, whether it's site of administration or another region. You could use a different second dose, but it's preferable to use the same first and second dose of vaccine at the moment. However, it is interesting. I'm watching the study with real interest. They're doing quite a big study in Bristol, looking at different doses of different types of vaccine as the first and second dose. And it'll be really interesting to see the results of those. So our current feeling would be is that we would do the first and second dose with the same type of vaccine at the moment, because that's JCVI's recommendation to do if at all possible. But we will be having a very watching brief on what's happening with the Bristol studies to see if there's any benefit of doing different vaccines. We just don't know at this stage, or whether there's any detriment or whether it's neutral. We don't know that at this stage, but we'll be watching it really carefully.
Ewan's got his hand up now, so before I come back to you, Juliet, I'll ask Ewan. Ewan?
Just a question from a listener. I know you're going to talk about the borders on Friday, sorry. Yeah. But they're asking about students coming home for Easter and if there'll be any sort of allowances for them to maybe do less isolation time. I suspect I know the answer for that already.
Okay, yeah, but and again, I don't want to avoid a question because I never try to avoid a question, but we'll have more for that on Friday. So I appreciate the question. Easter's not far off, but we'll have more information on Friday. Juliet, your question.
I was interested to find out what the take-up has been like when it comes to testing the older school children, because I know there has been a lot of testing taking place of older school children before they went back, and now they are back. How has the take-up of that been like, and have people kept still getting tested? Because obviously, if they get tested for, I mean, I don't know how often they're being tested, so I was hoping you could give me a bit of a clearer picture of what's taking place.
So with the testing program, it's a self-swabbing program. So the teachers are doing the self-swabbing down at the East Arm, and most of the students are also going down to the East Arm. Some of them are going through the PEH. We're using a PCR-based assay for that. What we'll do is we're going to look at the uptake. We need to collate that data and have a look at it. And I thought of doing it this morning, but then time ran away with me. But we'll have a look at those numbers and see what the overall percentage uptake is. There's been a really good uptake in the teachers prior to the schools going back for those key worker teachers. The uptake was really good with regard to that. But we can present some more collated data. So I'm sorry, Juliet, I'm not avoiding your question. I simply don't have accurate data for you, but I will undertake to get that for you.
Thank you. I don't see anybody else's hand up. Juliet, was that your last question?
I've got one final question, but I thank you very much, Dr. Brink. I'll be really interested to see those figures when we do have them, so that would be brilliant. I've got one other question, which I recognise may not be one which either of you can answer, which may have been one for Paul Whitfield on Friday, but I just want to put it out there. We've been contacted by a local businessman. I don't know what trade he is in, but he said he's had a real problem because he's got to work in people's homes. And he's found that people aren't necessarily wanting to have tradespeople in their homes when they're shielding or during these vulnerable times, but they feel they can't get co-funding anymore. So is this being taken into account when dealing with the co-funding applications?
Well, I think they need to come back. If there is that problem, and obviously it's affecting the turnover of their business, yes, they ought to come back and we can look at it. I mean, I'm not saying that the answer will be that those funds will be automatically replenished or substituted for the income they otherwise had. But if there is that issue, then it should be referred to, because it will be considered. I don't see anybody else with any hands up. So thank you very much, everybody, for their questions. As I say, we'll be back on Friday with more news. And as I said at the beginning, it's not actually, the sun isn't out there today, but it is coming out in the Bailiwick. The temperature is getting warmer in the best way, and we're moving in the right direction. So thank you very much, everybody. And we'll see and hear from you again, hopefully on Friday. Thank you very much.